This is Local Edition. My name is Brad Pomerance, and we're in Sacramento today. We are joined by Jim Wood. He is a member of the California State Assembly. And so I'd like to speak with you about health care. As some of our viewers know, my wife has Crohn's and colitis and asthma and eczema. She's wonderful. I love her, but she's got a few medical ailments. And there are a lot of medications she needs to take. And sometimes it's hard to kind of keep track of what's going on with my wife and her medications. And that's a problem that you're aware of. Several states have addressed it by adopting what's known as comprehensive medication management. Tell us a bit about it.
Well, comprehensive medication management is an opportunity for basically pharmacists and pharmacy techs to actually act as coordinators. So it's not
team captains.
Team captains, exactly. It's not unusual that physicians, patient may have multiple physicians, multiple medications, and the one person that sees all this is oftentimes the pharmacist. So he can be looking at these things and saying, hey, you know what? We got 10 medications here. We have some interactions. Maybe we need to be talking to the physicians and managing this a little better.
So you'd think because my father is a pharmacist, I could have him help me with my wife, but that's another conversation. But I understand where you're going, though. I mean, your point's well taken, is that we do need a team captain. So what does that mean in terms of a legislative solution? I understand certain states have already addressed this. What can you tell us?
Well, certainly there was a pilot project here in California that did that. USC did it, about 3 years of work that they did. Pharmacists managed an average of about 9-10 medications per patient.
Oh, wow.
Significant amount. The overall cost savings just in that pilot program was about $43.7 million. A return of 4 to 1 on the investment.
And that's a cost savings, presumably.
That's a huge cost savings.
To the insurance company.
Exactly. And we're talking just about 3 cities.
Right. So I guess we're still figuring out what the benefit looks like, but presumably it would be a benefit that would pass to the pharmacist through the insurance company.
Possibly, yeah, we're still looking. We're still looking at that. You know, obviously you'd love to be able to do something like this statewide because the reality is that not managing medications well leads to a lot of unintended costs. And so, but maybe this looks like a pilot project involving counties now instead of not cities, and actually we can prove its worth and then maybe expand it statewide.
The other question, in addition to prescription, whether you're using the correct medications and they're not contraindicated, is the question of adherence, compliance. And as I understand it, a lot of the population who's challenged as it relates to compliance is on Medi-Cal. And so it seems, I understand with the USC program, they were looking at a Medi-Cal population, Medicaid population. And so explain that element to it if you can, sir.
Well, it's difficult to manage, and these are difficult to manage. So in these cases, they were actually sending out pharmacy personnel to houses to actually look at the medications and help people coordinate things. Yeah, and it seems like that might be real costly, but the payback on the other side of that is if you can limit the exposure and the potential side effects, you'll keep people out of hospitals and emergency rooms, that sort of thing. So that's a benefit. And there are simple things. Oftentimes people just need a little bit of education. Maybe they're not storing their medications in the right place. We heard of a story of a person who was actually was told that he needed to store his diabetes medication in a refrigerator. Well, that's great. Well, he owned a refrigerator, but it wasn't plugged in. So that was one of those things that somebody could come and say, oh yeah, okay, well maybe we need to be plugging that refrigerator in. You're doing everything right, but we need one more step in the.
And so he's taking this medication. He doesn't know
that it's expired, going bad. Exactly. And so they're not getting the outcomes that they need, and so they're wondering. We're giving him the medication. He says he's taking it, but we don't know what's happening in the home. So they go out to the home and they find, what? It was just one little step.
So where do you go from here as a legislator? Are you looking to work with health committees to try to create a pilot? Where are we on
We're looking to introduce some legislation to actually do this. Obviously I'd love to do something statewide. I know this is a big project. I would, maybe it becomes a pilot project involving a couple of counties and picking out, especially rural counties. That happens to be something new and near and dear to my heart, representing a very rural county. We can get people out there into communities where transportation is often difficult too. So we'll see where it goes. I think it's a novel idea, but it's actually proven itself in a small pilot project.
But also in other places as well, as I understand it, it's proven itself in Minnesota, in Connecticut. U.S. Public Health Service has used a program like this. So there are significant peer-reviewed studies that suggest this could be of benefit.
Absolutely.
You mentioned you represent rural counties, and I want to dig a little deeper on that question. I've learned this term, doctor deserts. And it's not just in North State, in the Inland Empire of California. There are doctor deserts. Explain what that is, sir.
Well, a doctor desert is basically an area where you have a very low concentration of doctors. So in California, we estimate there are like 214 doctor deserts. And what does that mean? One physician in 3,500 people. Contrast to the state average of one physician in 1,000 people, and you can see where the problem is.
Of course.
A doctor desert.
And so why is the problem compacted or made worse based upon what we have in our codes as it relates to the ability of a hospital to retain and hire a doctor? Explain that, sir.
Well, the problem becomes really acute in what we call these critical access hospitals, which are hospitals that are 25 beds or less. They're in rural communities.
I see.
Really hard to attract physicians to these communities, number one, anyway. And because we have ratcheted down reimbursement costs and all the costs of medicine, and it's really hard if you're a doctor to go and set up a practice and get hospital privileges. But what I'm looking for is an exemption that would allow hospitals to actually hire doctors.
Explain. So right now, a doctor is not an employee of a hospital, or is it these critical access hospitals that we're focused upon?
I'm focused on critical access hospitals. Right now, there is an exemption that allows hospitals to hire physicians. County hospitals can do this, UC hospitals can do this, and it works. For-profit, nonprofit hospitals cannot do that. It's just not.
It's through doctor groups or whatever it may be.
So you might be employed through a doctor's group or whatever.
I understand.
So what I'm trying to do is say, look, I'm a small hospital in Trinity County, say Weaverville. I really need to get a doctor on staff here, but I can't find anybody who can come and set up a practice. So I want to hire a doctor. I want to hire a doctor, and we'll help him get going, and we'll be able to provide that. What does that do for a community? Well, it keeps people in the community. They're not going to have to travel 100 miles sometimes to another doctor's office. It'll keep people in their community.
But what's the policy reason against? Forgive me for asking you to speak against your proposal, but I'm trying to figure out why not.
Well, I think if you're looking at this on a broader scale, do this as statewide. I think there's a concern, and it's a valid concern, that hospitals could control how doctors provide care.
I understand.
The reality in these smaller communities, it isn't going to work that way, because the doctor needs the hospital needs the doctor. They're going to figure out a way to work with it. And if it was a really difficult problem, we'd hear about this more at the UCs and the county hospitals.
And I'm going to hold up this map, if I may, and you don't need to be a student or an expert in California geography. These red dots are where there are critical access hospitals. We know where these red dots are, rural California. And so these are the hospitals you're looking to target so that you can create a scenario whereby there can be medical professionals. So, Bill, ready to go? Where are we?
We are actually looking to introduce the bill. We've got through the end of the month to actually do that. So we're actually looking to that. But we're meeting with stakeholders. I want to make sure that people are on board with this. There was a pilot project that actually did this a few years ago. It was successful. But when the pilot project went away, the doctor went away. So we know it works. We want to bring this back specifically around critical access hospitals.
And I would presume with the Affordable Care Act rolling out, and fairly successfully in California, there'll be a need for more doctors because there'll be more people accessing health care as opposed to running to emergency rooms.
And we see that it's acutely apparent in rural communities. We need more doctors, and we're just not producing them at a fast enough rate.
So in our final moments, you're a new member. How's your new job going?
I love my new job.
Tell me about it.
It's an amazing challenge. Every day is a different day. But I think the biggest challenge for me is I am one of these people who wants to be everywhere that I can be all the time.
And that must be hard with a district that runs 300 miles up North State.
I have colleagues who can get across their district in 20 minutes. It takes me 6.5 hours to get from one end to the other end of mine. So I spend a lot of quality car time.
I can only imagine. His name is Jim Wood. He is a member of the California State Assembly representing significant portions of beautiful North State California. My name is Brad Pomerance in Sacramento. It's Local Edition.